So we have a 80-year-old patient that's been here for 20 days, was on Optiflow, high levels, difficult to wean, mostly 90 to 100. Had periods of being on BiPAP, would respond well to the BiPAP. We were putting on the BiPAP nothing excessive, like a PEEP of 8 and a pressure support of 6. The oxygenation usually would drop about by 20% the requirement, so he does respond somewhat to the positive pressure. Thought that the patient was doing well. Had been off at least 3 days off the BiPAP, and suddenly went into rest distress. Tried the BiPAP, but there was a significant amount of rest distress, so we had to intubate. So we're going to do the bedside pulmonary mechanics, and then we'll do a PulmoVista. We'll put the settings there, and we'll see if the PulmoVista and the PEEP study are similar. The ideal PEEP that's indicated with the global compared to the regional distribution that we can see with the pulmonary, with the PulmoVista. One moment. Sorry about that. And once the mechanics are done and the tomography is done, we're going to give a trial of APRV. So the mode is called PC-APRV, and it's with the Drager vent. What's good about this is that we don't actually set a P low and we don't set a T low. We set the P high and the T high, and we use auto release, which terminates the expiration by looking at the peak expiratory flow, and we set a percentage. So if the goal is usually 75. Research has showed that offers the best alveolar stability. So technically, unless there's resistance through the ET tube, the ideal PEEP should be very similar to the P low that we're going to get with the 75% expiratory release. Okay, so the patient currently is on ACVC, 75% oxygen with a SpO2 of 92. We're putting 350 for now, respiratory rate of 30 and a PEEP of 8. That's where we're going to start. So let's do this. All right, so we're going to take we're going to do a plateau right here. Good. It's hard to do with one hand. All right, so we're at 29 with a PEEP of 8, and we have to do the total PEEP. All right, 8.8. We're going to titrate that up. Going to go up to 9. So we're doing just the global mechanics right now, the traditional global mechanics with ACVC and the square waveform. All right, we're doing a plateau again. All right, and we're gonna check here. So 30. We're gonna do 10. Give it a few breaths. Doing the plateau. Freeze the form. We're at 33. All right. So just from the global mechanics, he's not going to have a very high PEEP requirement. So we're definitely not 10. Let's put it back to 8. I just redid this previously. All right, so this was the previous one I did, so that was the second time actually that I did it. So we see that we went from 8, then 9, there was a significant jump, and then there was an even more significant jump. These are the plateaus, guys. These are the PEEPs, and these are the intrinsic, the total PEEP basically. So it seems like PEEP of 8 is the ideal PEEP. So we're going to do the PEEP study, and we're going to check out what the PEEP study says as an ideal PEEP. Then we're going to give a trial of APRV, and we're going to look at the auto release option that allows the patient to expire to a certain percentage as explained before. So it's called auto release on PCA-APRV on the Drager ventilator. And basically, once you're on the P high and you come to drop to the P low setting, again, it's not set with auto release, and the T low is determined all based on the auto release button. So it's expiratory termination and it's a percentage. Example, if the patient's peak expiratory flow is 100 and I'm setting on my expiratory termination with the auto release option, if I set it to 75, then that P high will drop to a P low setting, and once it hits 75 liters per minute of peak 75 liters per minute of the peak expiratory flow, which we're just giving as 100, for example, it returns up. So let's get it going. Battery last. Okay, so looking at the ideal PEEP from the Global Mechanics, we have a drive pressure of 18. So what we're going to do for the PulmoVista PEEP trial is we're going to transition and we're going to do the same delta, very similar delta. Just give me a moment. Okay, so let's transition over here. We're going to put this down to 26. All right, and I'm going to put this down to 8 to 6. Sorry. All right. All right, so this is on ACPC with a peak expiratory pressure of 26 and a PEEP of 6. We're going to keep that same drive pressure of 20. All right, the calibration just terminated, and now here we're looking at the 4 regions of interest. That is your ventral, mid-dorsal, and dorsal regions. Each tidal volume here is given as a percentage. So the 344, okay, 70%. So you can multiply 344 times 7. That's how much air is going up in the ventral region. Same thing, multiply 42% of that, and you get a distribution of the ventilation regionally. Okay, the most important here is the dorsal region, where you have the gravity-dependent regions, as well as down here. So this is normal, is usually 8 to 15. The mid-dorsal is 35 to 40, 35 to 40, and again, 8 to 15. Okay, so now we're going to do the PEEP trial. So we're going to press reference, okay? And this reference is these parameters, okay, 6 and 26. What we're going to do is, we're not going to go very high. I might go up to about PEEP of 10, and then we're going to do the PEEP trial. So right now, the PEEP trial is already in progress. We're going to, give it a good minute or so, and then we're going to go up by 2. It's important when you do it to do it in ACPC and to keep the similar drive pressure. So you don't make a mistake, you're going to go to vent settings over here. Okay, and then after, I'm going to press here my PEEP, and see, look, so you keep the similar drive pressure and you don't make a mistake. Sorry about that. Yeah, so you go to ventilator settings, then we pressed the PEEP, and then we linked it. Notice, see, when you link it, see that it says delta 20, and now I'm going to bring that up to 8. All right, and we're gonna just wait and keep that for about a minute. Overall, there's a decent distribution of ventilation. We could either look if we're lucky enough to have a CT scan, or check on an X-ray to see if there's something happening on the right dorsal region. Patient's currently at 30 degrees head up. All right, just wait a little bit longer. We're gonna go up again, there, press link. I'm gonna go up to 10. All right, so I did the global mechanics, remember, and the PEEP seemed to be 8. So I'm not going higher than that. I just want to cross-check with the global and see if there's any improvement. I forgot to mention prior, I did do a lung recruitment 30-30 prior to starting. It's recommended, obviously, to do that. Okay, and that's pretty much it. I'm not talking to myself, I'm just filming the screen for Alright, so now we're done, so we're going to go to view, and we're going to go to diagnostics. Alright, let's just fix up here. So the bottom green here is the PEEP, what I'm seeing here. So you see the staircase, so you're going to want to place those in the proper position. Usually the computer will do it itself. Sometimes it acts up and it doesn't. So I'm going to remove this one, it's redundant. And then after, I'm going to go to 10, alright. So I'm going to go a little fast, my battery's about to die. So we did 6, 8, 10. See this button here? PEEP trial, we're going to press that, and we're going to click it. Alright. Okay, so looking at the results here, orange is not a good thing. It means that there's possible over distension when we're going towards the higher PEEPs. And any white saturation here that would appear, that color is indicative of possible atelectasis, suboptimal PEEP. So if you can look up here and you'll see the color saturation. You can also look at the numbers over here as well as the vectors. So we see the optimal PEEP appears to be 6. There's not much of a change, there's just a peanut of a change here, and over here all of a sudden you have a drastic increase in possible over distension, showed by the slight orange saturation there. It's hard to see, but there's a little bit of white here, there's nothing at all here, and then there's slight orange. So it really matches exactly what our global mechanics, but we have more than just global mechanics. We have actually the regional distribution of where that air is going. So I would choose between 6 and 8. I would go and I would put the PEEP, ideal PEEP at 7, right in between, so you get the best of both worlds. So you notice that we've recruited compared to the reference that was 6 at the dorsal region. Now we're within the 8 to 15 range. Sorry, I'm catching a cold, my voice is a bit cracky. Notice with APRV how the lung stays well splinted open. Alright, and that's when you have a 75% expiratory termination that is used when we do the auto release option. Okay, very well recruited, and just the image shows that there's no open and closing, there's no cyclical opening and closing. We're falling on the ideal PEEP. Let's do it one more time. There we go. Around 8.4, 8.9. And when you look at the global values that we did, the setting was ideal at 7, but the intrinsic PEEP when we set it at 7 was actually very close to 9.1 when you look at the mechanics that I did on the first paper. Now if we set the exact same, the P high, instead we're on ACPC. If you set it, the P high will set the pressure control at 30. We'll set the optimal PEEP that gives an intrinsic PEEP probably close to 9. Let's go do that. You can see the previous ones that we were doing, the 9.1, 9.9, now 7.6. There's less air trapping, but on the previous one, the mechanics were arriving close to exactly the P low that we had. Where am I? Where am I? Oh, there. When we were doing it, it was 8.8, 9. We're going to set the patient on a rocuronium infusion. And if you look at here, notice the difference. See how the APRV was really hovering and splinting the lung open, and now on expiration it's going back. Right? So it's just obvious when you look at the tomography which one is keeping the lung more stable. Let's just try, let's just try and put this up here. Even, let's say to 8. You see? Now let's go back to APRV. So these are similar pressures. The pressure control is 30, the P high is 30. The optimal PEEP is set here, similar to the P low. Let's just do another intrinsic PEEP. So P low is equal to the PEEP, and the P high, oops, that's a P.1. Now, mind you, we have to start the rock infusion because he's actually fighting a bit. So you can see that he's pulling a little bit, but you see what I mean? When you set the auto release at 75, it'll always fall on the ideal PEEP. Unless you have a lot of resistance through the ET tube, then the resistance during the release will cause a higher PEEP. So let's switch it back. Actually, this is, the pressure control was 30 before, so now we have even less. So let's look. We can't deny that APRV is way superior for the protective lung for recruitment. Now, also keep in mind, okay, the misconception. Okay, let's see. See, this is APRV. But it's called PC-APRV because when you're using an extremely low T high, the profile that you're receiving from it is basically ACPC. It's very close. You got the decelerating flow waveform, pressure, controlled breath. Another important thing to keep in mind, the volumes. If you're not using a slope, always use a slope, okay? Watch the volumes drop when you don't use a slope, drastically. They'll just keep on dropping. Very important, PC-APRV, add a slope. So you see what I mean? Go back. If you don't add a slope, you're gonna have trouble getting proper volumes. You're gonna think that the APRV is not working very well. There we go. We're back up to good volumes, okay? Usually 0.3, I've noticed if I've tried to go beyond 0.3 and it doesn't work very well, okay? So the proof is right there. Can't deny with the tomography which one is a superior mode that offers superior tidal volumes with less pressure, and you can perform quite well with high minimum ventilation. There's slight efforts here, but we're starting a rocuronium infusion. Okay, guys, thanks a lot. Just for a little extra, I already said goodnight, but I lied. So I'm going here into the end expiratory lung impedance. All right, so the reference is here. This was APRV. You can tell because there's no PEEP with the green, right? There's no PEEP. You see it appear here when I put the ideal PEEP for ACPC. So let's look over here when I get, okay, all of a sudden I switch to ACPC. Okay, look at the difference. And now we're actually using here lower peak pressures, and when we switch to ACPC with the ideal PEEP, we actually have higher peak pressures in yellow, and we have massive loss in electrical impedance. which basically is telling you that for that set pressure, which is higher, you're getting less volume. All right, so that's when you use end expiratory lung impedance, which represents end expiratory lung volume. The more volume, the bigger the impedance. Okay, now I say good night for real.